Hey guys, I'm Jarrett.
I'm Charles.
I'm Steven.
And we're doing our presentation on PACU. We actually had two patients, but we chose the one that was a little bit more in depth. And really, the only difference between the two is one was being discharged back to the hospital, and the other is being discharged home, which is the one we're going to tell you about. Our patient is Mr. Potter. He is a 69-year-old male that had a
He had an inguinal
hernia
repair and is under general anesthesia.
He's already intubated. He's coming from the OR intubated with O2, and he's being brought by the CRNA and OR tech. So the CRNA is bringing to us, and we're going to get a report from them. Make sure when we get a report, we want to know what procedure he had, any pertinent health history, any meds that have been given, any estimated blood loss, and their fluid status.
Including the anesthetic agents.
Yeah. But he was like I said, he's a 69-year-old male. He was under anesthesia for 53 minutes. The operation took 38 minutes. He was, like I said, he was under general anesthesia. They were going to do a spinal block because that's what they usually do for inguinal hernia repairs.
And he's allergic to morphine also.
Yeah, he's allergic. Yeah, he's allergic to morphine. But since he was anxious about surgery, so they used general anesthesia instead of a spinal block. He is an ASA2, which we'll get to that later. He is a 1.5 pack a day smoker with a history of chronic bronchitis, and he was given no pre-op meds. He has an 18 gauge angiocath in the right hand and is intubated with a 7.5 ET tube, and he is not fully awake yet. During surgery, he got 900 milliliters of lactated ringers, and estimated blood loss was approximately 20 milliliters. The anesthetics they gave were pentothal, anectine, fentanyl, tracrium, diprivan, and
isoflurane and nitrous oxide.
Good job. So we get this patient in the PACU, phase 1 PACU, or level 1 PACU, and pretty much right now what we're looking for is just basic life-saving or life-sustaining measures. So of course, when you get a new patient, the first thing you want to do is assess them. We're going to assess his airway first. He's still intubated at this point. His vitals are, his pulse are 71, oxygen saturation 97%, BP is 158/84. His pulse and BP are good, which tells me he's still got good circulation. We listened to him, and he's got clear breath sounds bilaterally. He's breathing at a normal rate and rhythm on his own. But just the ET tube is still in. So we're going to observe the patient as well as his vitals and check his apical pulse, and his apical pulse is still strong. So that tells us he's getting good circulation. Next, we're going to look at his orientation. His eyes open spontaneously when he's spoken to, and he can semi-follow commands. His skin is pale, warm, and dry. No pallor, which you want to check the skin, and the pallor is indicative of decreased volume. You can also check that with turgor. As far as the volume loss, you can also check in the oral mucosa and palms and see if they're pale to check for hypovolemia. But and then we also notice he has no signs of cyanosis. A factor that we're going to look at now is smoking. As we talked about smoking, they have a decreased time for healing, an increased healing time. It can cause complications with cardiac dysrhythmias, and the biggest factor is they're going to have a lot more secretions than usual, and they may not be able to clear secretions on their own.
And that's going to be a concern since he's still intubated.
Right. His ASA level is a 2. This is just telling us, he's got mild systemic disease that's well controlled. He's not brain dead, which would be an ASA 6.
And ASA 1 is really systemic disorders.
He's perfectly healthy. So we're going to use universal precautions. Still, even though he's out of surgery, we're going to make sure he's the right patient, right surgery, right site. And this is JCO mandated. So you want to make sure you're doing the right thing to the right patient. So once we make sure he's hemodynamically all right, stable, we're going to look at his surgical site, make sure he doesn't have any dehiscence, bleeding, anything like that. He comes to us with his wound is covered with a tegaderm and a gauze pad. The tegaderm, of course, to help prevent infections. There's no bleeding or ecchymosis or swelling noted. He's got a scrotal support that is just to help him, maintain his scrotum. And we notice that there's no swelling to the scrotum to indicate any kind of bleeding. Sometimes, if they have a scrotal surgery, you can have bleeding that would go down to the scrotal space. He's supine with the head of the bed slightly elevated.
And as we mentioned earlier, we're going to provide him with as we mentioned in class, we're going to provide him with an ice pack to try and limit any swelling before he goes home, or at least PACU.
Right. He's got humidified oxygen on. That's going to help decrease the irritation of the respiratory mucosa and facilitate expectoration of secretions, which is getting them out. You want him to get out secretions, especially since he's a smoker. His O2 sats are fine right now. With the O2 on, he's at 97%. And the O2 sat is actually a measure of the arterial oxygen saturation. And so we want to make sure he maintains that. As far as PaO2 and as it relates to the oxygen saturation, you want to talk about that?
I can read it. I can't talk about it. It is represented by the oxyhemoglobin dissociation curve. With PaO2 tensions of 60 millimeters of mercury and above, hemoglobin is at least 90% saturated with oxygen. The amount of oxygen available to tissues is greater. Higher PaO2 tensions do not significantly increase oxygen saturation, and the amount of oxygen available to tissues, although the amount of oxygen dissolved in the blood will increase. So once you get to 60 millimeters of mercury, you're not really going to improve your oxygen saturation either way. Lower PaO2 tensions below 60 millimeters of mercury, however, reflect a severe decrease in the amount of oxygen carried in the blood and are going to cause a significant drop in the SpO2, resulting in severely limited supplies of oxygen available to the tissues.
Things that can lower your PaO2 would be things like hypertension, alkalosis, decreased PaCO2, and all this, like they said, is going to increase your hemoglobin affinity and reduce the amount of hemoglobin available for oxygen to bind to. But he's not. That's not that. He's good, Mr. Our patient's good. Bless his heart, I forget his name. Mr. Potter's good. He's at 97%, and we're going to continue to monitor him. So we're monitoring and just kind of making sure he's okay. Oh, good. He's good. And all of a sudden we notice he's got some secretions in his ET tube. We go over there, listen to him, and he's got bilateral rhonchi. And so we're going to get ready to suction him because we don't want all that gunk in his airway. We're going to suction him through his ET tube. So we're going to raise the head of the bed and explain what we're about to do. When we suction the patient, we're going to hyperoxygenate him before that to get his sats up. And then we're going to do the suction. Make sure we have at least 2 minutes between attempts and oxygenate between attempts to keep his sats up. And when we suction him and we get out some thick white mucus, some nasty stuff. But he's good. He's breathing better. He doesn't have any secretions in his tube. But we notice he starts to shiver a little bit, and this is a normal sign that he's cold, and this is the body's mechanism to generate heat.
He's currently at 96.4 degrees. So
he's currently
low.
He's a little low. He's good. Some things that can cause the hypothermia is the anesthetics. The temperature in the OR is cold as get out, and the pre-op skin prep they use is cold, and so they can it's a source of to have hypothermia. Old people and young people are more susceptible to hypothermia, and so
Thinner skin,
and he's got he's 69. He's no young buck by any means, but
perhaps less body fat too.
Yeah, less body fat. He's probably he's a thin guy. He's 180 something pounds. So we're gonna look into interventions to fix this, such as warm blankets or something like that. As far as anesthesia goes, anesthesia has 3 phases. You have your induction, maintenance, and emergence. He's already been through the induction and maintenance phase. We're dealing with the emergence phase. During surgery, they gave him pentothal, which is a barbiturate. It's used for sedation and amnesia purposes. It can cause respiratory and cardiovascular depression and laryngospasm, which we'll get to later. So we want to watch that.
However, he should be over that by the time he gets to the PACU.
Right, it's short acting. The succinylcholine or SUX is a neuromuscular blocker. He got that, of course, to relax his diaphragm and maintain during anesthesia and during the initiation phase of anesthesia, so they can intubate him. With this, we want to watch for signs of malignant hypothermia. It's it can be life-threatening, so we want to watch for that, and we want to catch it before it gets to the actual hyperthermia part of it, because that once it's there, it can be bad. The tracarium.
Tracarium, it's a non-depolarizing neuromuscular blocker. It was administered IV from Mr. Potter for maintenance of muscle relaxation during the surgery.
It's another maintenance drug. Diprovan, famous drug. Michael Jackson had it. Too much of it. It's a anesthetic and is used for maintenance and induction of anesthesia. The isoflurane was a muscle relaxant that he got, and then he also had inhalated nitrous oxide. A lot of common side effects of these would be
lower respiratory distress,
nausea, vomiting. It's really common with the after anesthesia. And of course, if an ET tube was used or an endotracheal tube was used, he's going to have a sore throat afterwards. So you want to make sure you let him know that's normal. And we're going to probably go ahead and make sure he's got PRN pain medicine ordered for when he's coming out or emerging from anesthesia, and stuff like fentanyl and other opioid analgesics. We got told from the surgeon that he injected Marcaine into the site.
Yeah, which is basically similar to lidocaine, or it's a derivative, and it's injected into the site so the patient awakens and they're going to still have some numbness in that surgical incision, and they're not going to be feeling any pain there.
Right.
Also, he gave them serotonin blocking drug, Enzamet or Dolacetrine. It's a 5-HT3 receptor antagonist, and it's basically to prevent postoperative nausea and vomiting. So it's an antiemetic.
Like it's a derivative of or in the same class as Zofran. At the end of surgery, they also gave him prostigmin, which is a paralytic reversal to help him start using his muscles again. and Robenol, I guess that's how you say it. But that helps to interfere with the vagal stimulation, keep blood pressure and heart rate up. But anyway, he's with us now, and we're noticing he's after the suction and everything, he's starting to become a little restless, and notice he starts reaching for his ET tube. So we want to discourage him from reaching for it, and to take slow, deep breaths when it's uncomfortable, yes, but it's there to protect his airway until he can maintain. We want to make sure we explain his purpose and any plans that we have or the plan to extubate him as soon as he can manage his own airway. So what we're going to do is see what his tidal volume looks like, and make sure that's within normal limits before we extubate him.
And I think that's at least 6 milliliters per kilogram,
right,
before he's extubated.
And he's 186 pounds, so that's about
505 milliliters.
505 milliliters tidal volume. And so we're gonna notify the CRNA that he might be ready to extubate. So we're gonna continue to evaluate him for extubation and ask him to communicate with a nod. Don't want to ask him to talk because he's got a giant tube shoved down his throat. We want to make sure that he can open and close his eyes purposefully, lift his head off the bed, make sure all of his neck muscles are intact, and follow commands like squeezing your hand or something like that. And so the CRNA was notified that he's ready to extubate, and we're going to explain to the patient what's going to happen when they extubate him. The tube's going to be pulled out, and make sure we get him to cough and deep breathe and stuff like that. Prior to extubation, you want to make sure you have them suctioned if they've got secretions there. You want to elevate the head of the bed and make sure that he's in a good breathing position, so to speak. So they come and extubate him, and after extubation, his vital signs are stable. But just for prophylactic purposes, the CRNA wants him to be on 6 liters of O2 via a mask. So we're going to watch for signs of hypoxia, which would be increase in pulse, which is an effort to increase perfusion. Going to continue to stress to him that he wants to deep breathe, educate him on how to splint. If he has to cough, or when he takes a deep breath, you want to educate him how to splint. Should have been done pre-op by the pre-op nurse too. We just want to continue to.
We're just going to continue to verify there's no cyanosis or any kind of dusky nail beds or anything like that would be an indication that he's not getting the necessary air. Right,
and you also want to evaluate for any airway obstructions, especially like laryngospasm, which can be brought on by the ET tube being removed, vomiting, suctioning, and secretions themselves. Some signs of laryngospasm are agitation, crowing, suprasternal retraction, and dyspnea. If it occurs, you want to get help immediately. Administer ventilation with oxygen. Don't flex their neck. You want to extend their neck and keep the mandible pushed up to protect the airway.
And administer positive pressure.
If it doesn't get better, they may have to be re-intubated with PEEP and a diuretic given, and anti-anxiety meds just to kind of calm them down after they pull a tube out of your throat. You want to watch for signs of negative pressure pulmonary edema. Usually that's going to resolve fairly quickly. And they're going to keep monitoring that even in phase 2. But our patient tolerates the extubation well. We're going to apply ice packs to his scrotum. And if he asks why, we're going to tell him, the ice packs are going to be applied to prevent inflammation and swelling. But up to now, he hasn't complained of any pain. He started moaning, grimacing a little bit, and then he's holding his sight and says he's hurting. Says his pain is an 8 out of 10, and so we're going to use some of those PRN orders we got for PACU and he's got 1 milligram IV push times 2 doses of Dilaudid. Want to make sure his pressure's good and his respirations are good before you give it, because it's a respiratory depressant. His pressure's 150/86 now. His respirations are 16, so he's good. He can have that. Your pain control is going to be really important with anesthetics or after they wear off. It's you want to make sure that they're not in too much pain, and because when you're in pain, you're kind of crumping over and straining, and it can prevent them from deep breathing, which could cause embolisms and atelectasis, and you want to really avoid that for post-op purposes. You don't want them, you want them to be fairly substantial respiratory wise,
especially if you've given them a respiratory depressant beforehand, i.e. the Dilaudid.
Some side effects of the pain meds that we're giving would be nausea and vomiting, urinary retention, hypotension, and respiratory depression, of course, like you said. So you want to make sure you have Narcan readily available, to counteract those drugs. But he's good. He gets his pain medicine and starts to feel a little better. We'll come back and reassess that in a little bit. But the charge nurse wants to know if he's ready to go to phase 2 or level 2 PACU. We tell her no, because he's not on room air yet. He's still on a mask, and they want him to be on room air for 5 minutes. And that depends on institutions. Every institution's got their own thing. But this one is they want him to be on room air for 5 minutes with SATs greater than 94 before they're discharged to phase 2 PACU. But we go back and look him over. His SATs are 97%, respiratory rate 16, non-labored. He's not cyanotic. He's got a good cough. He's using the splint method we taught him, and so we say he can DC the mask, and just want to further encourage deep breathing and to keep his lungs expanded, prevent atelectasis. He's calm, cooperative. We reassessed him and said the pain meds helped a lot. The pain went from an 8 out of a 10 to a 3 out of a 10. So the pain meds did good. We had a good positive intervention. And he's got Toradol given. He's got Toradol ordered, which is for breakthrough pain, which would be anything above what he can't tolerate with the opioid.
It's an NSAID, and it's also meant to reduce the dose of the opioid he's receiving.
Right. And he's also going to be going home with some Toradol, but want to make sure that you tell him make sure you don't use that more than 5 days to prevent any kind of bleeding. And it's also contraindicated if bleeding problems are imminent or possible. But he's kind of chilling, just sitting in bed chilling. He's awake, alert, and oriented times 3 now. He's got a patent airway. He's doing good deep breathing, regular respirations. His skin's gone from pale, cool, and dry to warm, pink, and dry. But he still hadn't voided. So that's the only thing kind of holding him back right this minute. He's maintaining his O2 SAT, and we think now he can go to phase 2 PACU or level 2 PACU. And so we get him packed up, get him off the monitor, and roll him over to level 2 PACU and get over there. And his wife's over there to greet him. She's ecstatic, and he's out of surgery, doing good. He's happy to see her. He's just still kind of, but vital signs are stable. He denies any pain at this time. When he gets level 2 PACU, he's got a little bit of soreness at the site, but no pain really. Get over there, and the nurse gives him some ginger ale, and he tolerates that well. He can swallow, which is a good sign. But the nurse is over there examining him. She palpates the suprapubic region and notes the distended bladder when she palpates. So what would be, or the
potentially have just urinary
retention from
some of the meds, especially those used as anesthesia during surgery.
Right. So we get him over there, and the nurse helps him sit to the side of the bed. Want to make sure that he doesn't have any kind of orthostatic hypotension. When he sits up, just kind of sit him up nice and slow, and have his legs dangle. Make sure once he's good sitting down, we get him to stand up, and he's like, I gotta pee, I gotta pee, I gotta pee. So we get him a urinal, and he voids 400 milliliters of clear yellow urine. After he's done, we sit him back down in a chair next to the bed. Check his pressure again. His pressure's good. He says he's a little weak, but he actually said that he can move easier than he expected, which is a good sign, I guess. He's doing good.
Ready to rumble.
Yeah. We get him up and walk him around a little bit. He does fine. Doesn't say he's dizzy. We check his pressure one more time. His pressure's 138/72. When he got there this morning, it was 142/80. So there's no huge change in pressure there. So we're good. We're good there. We're gonna let the PACU nurse do what she does, and make sure that his wife fills his prescription for the Lortab. We're going to give him to go home with, along with the Toradol. For 5, make sure that you don't take Toradol for more than 5 days. And as tolerated, he can wean off the Lortabs and change to Tylenol instead of the Lortab. Try to get on the over-the-counter stuff instead of the opioids. The level 2 PACU nurse DC's his IV, and he's cleared for discharge home 1 hour after admission to the level 2 PACU. Want to remind him he's got a follow-up appointment in a week with his surgeon to check his site. Want to make sure we give him his discharge instructions, which are reporting elevation in temperature, which could indicate infection. Protect and monitor his op site. Make sure there's no redness, or make sure there's no prolonged redness. There's normal redness, 3 to 5 days after surgery. Avoid any strenuous activity because his inguinal canal is still sensitive.
No rugby for a few days.
No rugby for a few days. Want to make sure he continues to do deep breathing exercises, keep his lungs good. Continue ice packs at home to decrease swelling, and make sure he doesn't drive home. His sweet wife's going to drive him home in their little old Lincoln and get on down the road. But he is discharged in the care of his wife, smiling, happy, and without a hernia anymore.
And while this patient didn't require it, we've discussed PACU Phase 1 and Phase 2 during his adventure, but I do think it's important to mention that the case study does mention that there is a Phase 3 PACU, and it's used for patients who require extended observation or intervention after they get discharged from Phase 1 or Phase 2, specifically patients that are at risk for bleeding or who have post-op nausea, vomiting, or in need of some sort of pain management that they can't just get something to go home with. And then they just be prepared there until they're able to meet back up with their family and they're ready to go. Anything else, guys?
Just that if they were getting discharged to a hospital, back into the hospital versus back home.
There are just a very few small differences. Basically, the discharge to the hospital as opposed to discharging to PACU is almost the exact same. I think that there's specifically a thing about verifying that the skin's not cyanotic. And let's see, I believe that the room air, while it's still recommended, you can still transport patients to their rooms with oxygen if it's on a physician's order.
And make sure you get a good report to your receiving nurse on the floor, and make sure your patient don't start crumping on the way up there. But enjoyed it. Hope it's been good for y'all. Peace out.